And it is, I'm going to pause the recording. Hi, folks. Thanks for joining us for another allcounselors.com webinar. This is the first in our inclusive therapy series, and I'm really excited today to be here with Dr. Cabell, talking about how to be an inclusive therapist to children and adolescents. Dr. Cabell joined DePaul University as an assistant professor just this past fall in counseling. She earned her Bachelor of Science in Psychology from Florida State University, her master's in school counseling from George Washington University, and her PhD in counselor education and supervision from Virginia Commonwealth University. Dr. Cappell, would you mind telling us a little bit about you and the areas that you're focused on?
Yeah. So I'm in the Chicago area, and as you mentioned, my master's is in school counseling. So I started off working with high school students. And so my passion area has always been with adolescents and even young adults, but I really, really like that adolescent period of life and working with children and adolescents and helping them to transition to whatever they want to do. And part of how I've done that in the past is through not only career development work, but also mental health and even trauma work as well. And so I really am passionate about helping youth through that career development lens, but then also recognizing that mental health and career are often interconnected. And so how can we address the mental health needs that you have and also pursue the interests that you have as well too. And so with that, I've had the opportunity to work in a variety of settings, high schools, residential, private practice, and currently I am on a federal contract working with federal employees, but then also their dependents on career coaching and counseling.
That's awesome. So kind of not just looking at the what's next after high school with teenagers, but all of this is connected, and part of getting to where you want to go is more self-understanding and support and so on. That makes a lot of sense. Is there any, aside from working on the career development, are there any other areas that you really see as being really important to adolescent development?
Yeah, well, I think first we can't talk about children and adolescents without talking about child and adolescent development. And I think a key aspect of that is childhood trauma that I think is oftentimes missing in part of the conversation around behaviors that children and adolescents might be exhibiting, but also counselors and clinicians being aware of some of the underlying traumas that are happening in childhood and adolescence and how that ultimately impacts development in the present day, but then also that ongoing developmental process. And so in addition to that career lens that I have, I also work with any clients that I see from that trauma perspective and assessment for trauma, and even in some cases, suicidal ideation too.
Thanks for sharing that. We've had a couple of folks come in. So just again, want to mention that we're talking with Dr. Cabell today about becoming an inclusive counselor to adolescents and children. As a reminder, Dr. Cabell joined DePaul University as an assistant professor in fall of 2020. And we were just talking a bit about the lens that she works through, including career development, overall mental health, and understanding the trauma that can occur in childhood and how that impacts immediate development and things that come later. So one of the questions I have is, do you think there are a lack of providers for this kind of group, of children and adolescents?
Yeah, I do. And that's been partly in just like the literature and the numbers, but then also just in my own personal experiences of working with children and adolescents and needing referrals to psychiatrists and being able to work with psychiatrists who have that specialization in children and adolescents, because that's really important. And often as a counselor, I won't refer any child or adolescent to a psychiatrist who doesn't have that clear specialization. But then also just even in my peers and colleagues, and kind of being that go-to person for them for consultations around like, hey, I'm working with this teen, I'm totally lost, I don't know what to do. And so I think, the literature and the client experiences and parents' experiences and having trouble finding providers for their children and adolescents also just aligns with the personal experience that I've had as well.
And that lack of providers, I think, also kind of adds to just the overall struggle in finding not only a therapist, but a therapist that your child can connect to. As much as it's a pretty personal and pretty vulnerable relationship for adults, do you think that that's even more so for children?
Yes, definitely. And I think that there's a variety of factors that lead to the lack of access to providers, or just even the quantity of providers. And I think just even as a counselor educator and working with the students that I work with, there can be this perception that working with children or adolescents is harder than working with adults. And then how that kind of, maybe those beliefs get started in a master's program. And then over time, you just decide, okay, well, I'm going to work with adults because I think that's easier. And then you never really lean into that additional training or being open to seeing children or adolescents. And I find that part of that perception is that is this kind of view that children or adolescents are maybe less capable of actively participating in the counseling and therapeutic process, when really it's just adjustments that we have to make as a counselor or clinician to meet the developmental needs of our clients. And that is across the age range, but I think for some reason there's a hesitancy in doing that to meet the needs of children and adolescents. I also think that counselors and clinicians are aware of the working relationship that you're going to have with parents or guardians as well. And sometimes that can be complicated. And again, a counselor clinician saying, what, I love kids, but I don't want to deal with parents. I've heard that a lot as well. And then I think too, just our own countertransference that comes up. So I've kind of heard peers and colleagues talk about, like, I just can't work with the younger children because I just want to take them home with me and save them. But recognizing that that's countertransference and something that we have to kind of work through ourselves. And so I think it's that that fear of not being able to set clear boundaries with children and adolescents, personally and professionally. And then also, I think that there's an added layer of countertransference that comes around fear of the mandated reporter role and the potential of doing risk assessments with children and adolescents too, and feeling afraid of that or not competent in those areas too, that can lead to people not going into this specialty area.
That makes a lot of sense. And real quick, we've had a few more folks come in, so welcome everybody. We're talking with Dr. Cabell. This is an allcounselors.com inclusive therapy series webinar, also sponsored by ILC or integrativelifecenter.com. I think that it makes a lot of sense around some of those fears, both with countertransference, but also working with parents. I think we hear that from teachers and a lot of folks who work with children, that working with kids is a joy for the most part, but that the real complications come in when it's that parent, guardian, other type of relationship. I'm curious if one of the things that can be difficult, maybe not after it's developed as a skill, but is those kind of observing those boundaries of confidentiality with children. Could you talk a little bit about what that's like?
Yeah, I think first and foremost is recognizing that the child or adolescent is your client. And yes, legally, there's some things that our parents are obligated to, but if you're always kind of acting in the benefit and from the perspective of the client, the counselor or the child is my client, then it allows us to lean into the agency that children and adolescents have. And so often what I do with working with children or adolescents is invite them into that process. Nothing is secretive about talking with your parents or that confidentiality process, the limits to that process, but then also, how can I share with your parents what you would like me to share? How can I maybe help to advocate for you or be that kind of middleman in the relationship between you and your parents if that's something that you want? And then also too, inviting parents into the relationship as well. And that takes some preparation, and for again, that child or adolescent is your client, and so we're working with them collaboratively to see, okay, if your parents come into the session today, what would you like for me to talk about? What would you not like for me to talk about? At what point do you want to speak? And so being kind of preemptive about building that collaborative relationship, not only with the client, but also with the parents, can be really impactful. And I think one of the benefits of, I know with the confidentiality, oftentimes counselors and clinicians kind of view it as this burden, but I think it's a real opportunity to make systemic change. So we're with a child or adolescent for maybe an hour, maybe a couple hours a week. And all that other time, they're with their family, they're with their friends, they're at school. And so it's not often that with even our adult clients, we have the opportunity to be a part of a family system that they go back to. But with children and adolescents, there's a real opportunity to make change within that family system, lead to more understanding and collaboration within that family system. And that can be through building those boundaries and those understandings of the confidentiality process as well. And so even just making that a collaborative process as well.
That makes so much sense. I know that with one of my kids, having their therapist model some of that behavior around being very open about, here are the things that I legally can tell you, but I won't unless Lars says it's okay, or unless your kid says it's okay. And I think that was helpful as a parent in seeing, okay, how do I support my child having more agency and being able to advocate for themselves in terms of privacy and needs and so on. So I could see that being a really, honestly, just a healthy way to help show some behavior in terms of respecting a child or adolescent's boundaries, and how do they establish those even with their family, especially with especially if there are issues going on there.
Yeah, I think, often it's about setting those clear expectations and boundaries from the beginning. And so one of the things that I even talk about in like the screening process or the initial process where people, are deciding what counselor they want to go to and what my style is, as I talk about, with parents, I set up that expectation that I'll do a check-in with you maybe every 3 to 4 weeks. And before that check-in, I'm also going to check in with the client, the child or adolescent, and get their perspective on what they would like to be shared as part of that check-in. And sometimes those check-ins might be a group check-in as well too, but helping to relieve some of that anxiety from the parents' perspective around, I'm trusting this person with my child to help with very sensitive and vulnerable topics or things going on. And so they want to know and understand what to expect. And so I think the more that you can do that on the front end of the relationship, the better off it is for both the child or adolescent, and then also for the parents or guardians.
That makes a lot of sense. Do you think that there are, kind of continuing in that vein, more challenges with adolescents and children when it comes to self-advocacy? And if so, how do you kind of deal with that or help support them through that?
Yeah, so I think again that agency piece, that children or adolescents, regardless of age, have some agency over their lives, and so the more that we as counselors can support and lean into that, the more that we can also teach teach them about self advocacy, but also in some cases advocate for them in our role as a counselor or clinician, and so I think with that self advocacy piece, part of what can be really powerful about counseling and that process in general is that clients of any age now have some language about the experience that they're having. They have some context or more understanding of themselves, of their triggers, of their coping skills, of why they do what they do, that they can then use to as part of that self-advocacy piece, as part of that explanation of asking for what they need. Also in the counseling relationship, you mentioned modeling. We can model what it's like for a child or adolescent to ask for what they need, and even role play what it might be like to advocate to parents, to advocate to the school system, whatever kind of the stakeholder is that we're doing that advocacy work with. And I just think too, even before all of that is teaching children or adolescents what advocacy means, what it looks like, um, and how they can play a role with that. Sometimes as adults, we throw around these terms and language that children and adolescents aren't aware of. And so we need to find a way to kind of break that down in a developmentally appropriate way, whether it's pictures, whether it's drawing or playing games, in order to help them to see that you have power in this process, even though it might seem like you're powerless, or sometimes you're even forced to come to counseling by parents or guardians or other key stakeholders. You still have a choice in what you want to say here, of how you want to use our time together, and how can even that the process of counseling be part of the advocacy piece as well.
When, having worked with, school systems and in school counseling, kind of, helping with those roles, do you find that in addition to a lack of providers for this kind of group, that there are also missing tools when it comes to identifying and managing access to special services?
Yes. When you say tools, one of the things that comes to mind is assessment. And I think along with the lack of providers is a lack of understanding or competency even around the assessment process with children and adolescents. There's not a lot of assessment tools out there that are geared specifically for children or adolescents, but there are some. And so one, being able to find those and be trained in them, but also being able to use the things that are out there and adapt them to fit children's needs. And so, for example, I might find like the Beck Depression Inventory, which is a Likert type instrument where clients will rate themselves on certain questions around depression symptoms. And maybe I'm working with someone, an adolescent, let's say, who's not at that cutoff age for the Beck Depression Inventory, but is maybe close, and I'm thinking, how can I make this adapt this assessment for this child? Well, maybe part of it is, instead of drawing those, or instead of having them rated on numbers, you use emojis that signify those differences in how they might be experiencing that symptom. Or you do it side by side with them. So the Beck Depression Inventory, for example, is something that a client can do on their own, but maybe depending on the age, you do it in the room with them, and we go question by question, and we make sure that there's that just reading comprehension piece that's not impacting those scores. And so I think that assessment can be a really important part of the counseling process. And oftentimes, I think for counselors and clinicians, they're more likely to see that for adults, but get a little bit nervous or scared about what that might look like for children or adolescents. One, in just finding the tools that are geared specifically and normed specifically on children or adolescents, but then also being able to be creative about how you adapt, common tools that we use to fit children or adolescents. And when you think about the assessment piece, that can also be an important part of advocacy too. Like if I know what my symptoms are, if I know how depression or anxiety shows up for me, then I'm better able to communicate that with others. Or sometimes when we're thinking about the school system too, in the realm of accommodations or things like that, now I'm able to get just even those systemic accommodations that I need to re-engage in the learning process.
I know that, with the last year of the pandemic, one of the things that has definitely suffered in most school systems has been access to services for kids who need them. Either it's not safe because they need to be accessed in person, or there's not yet been a way to adapt some of those services so that they can be helpful and meaningful when you can't have that in-person time. So I think it's interesting to consider, and I'm curious what you think about whether or not there will be some long-term impact on ways that children and adolescents can access services that they need as a result of this very long, very difficult time. Because I think, we're seeing people talk more and more about how children are very much impacted by being at home all the time, by not having time with their peers or with certain family members, or just being kind of stuck in the same place.
Yeah, there's a lot to unpack there. And I think first and
Yeah.
foremost, we don't know the long-term impacts of this pandemic yet, because we're still very much in it, and school systems adjusting and adapting and trying to go back, and then that not working, and then just even that transition piece. And when we think about development and child and adolescent development, we know how important it is to set expectations around transitions and to help with the transition process, because that can be very difficult for children and adolescents to grasp. And so just in that very space of not being able to transition or prepare for virtual learning, what are the impacts of that? And we don't know yet. But then there's that piece, like you mentioned, about services. And so on one hand, I think the pandemic and everything that has been going on has offered or allowed people to lean into telehealth in a way that they weren't before. Not to say that telehealth wasn't happening before the pandemic, but definitely not at the rate that it is now. And so that also, that telehealth aspect can widen the opportunities for access to providers, and considering those specialty areas around children and adolescents, that, okay, maybe I don't have to stay in, my 5 to 10 mile radius. I have options online for screening and things like that. And at the same time, that could be a benefit. But on the other hand, we know that there are systemic inequities in just internet access, in just even having a safe and secure home environment to engage in the telehealth process. And so we're still, even though there might be more like just technical access to providers, there's still systemic and racial disparities in children and adolescents being able to get what they need in that way. And then the other, I think, added layer too is that assessment piece that often we have. I know in my master's program, which wasn't that long ago, I didn't get trained in how to convert some of these assessment processes through, Zoom or whatever telehealth platform I'm utilizing. And so there's a knowledge gap even for clinicians on how do I even, if I do have the opportunity to be a part of this assessment process for children and adolescents, how do I convert some of those things in this virtual space? And so I think that there's a lot of barriers that we just don't know the impacts of yet. And kind of along those same lines is that social piece. Like we know for children and adolescents, the importance of social networks, of play for younger children, and how the pandemic has shifted that and their access to their peers and that the isolation that comes from that. And so I think that as counselors, being aware of those barriers and also transparent about those barriers and the ambiguity, like, hey, it's not just you who doesn't know. Like, you're not alone in this process. You know, we're all adjusting and adapting, and that's really unfair. It's really hard. It's really disappointing, and just validating that experience, I think, first and foremost, is so important for children and adolescents at this time.
Oh, thank you. And yes, that was definitely a multi-layered question. So I appreciate you walking through that. Just a quick note, folks, if you have any questions, feel free to hit the raise hand or the Q&A or chat buttons down at the bottom of your Zoom screen. I'll hold most of those questions for the last 15 minutes, but we'd love to know what you're thinking, what you'd like to learn, what you're curious about. I think one of my questions too is, while we're talking about assessments, what are some things that providers should think about assessing for in addition to a presenting issue, or the main reason that somebody's come in to see you?
Yeah. And so I mentioned in the beginning that kind of trauma lens that I hold in my work with clients. And so um, I think that very much holds true in when working with children or adolescents, that oftentimes, like when we're thinking about childhood, oftentimes we might get a referral because of things that are happening in school. So maybe acting out in the classroom or with peers. And so I think that being able to see children and adolescents as not just their behaviors, but that those behaviors are a form of communication, and that oftentimes some of those things that we perceive as negative, maladaptive behaviors might also have a might also be related to trauma that they might be experiencing. And recognizing that trauma isn't just, you know, an experience. It's it's a stress response. And so for children and adolescents, sometimes, I remember in the school setting, a breakup happening for a young girl that I was working with, and that being, devastating to her at that time, and then grades slipping as a result of that, or then maybe fighting with your other friends as a result of that. But really working from that perspective of that breakup for you at this point in time is a trauma that you've experienced, and you're having a very real stress response to that. And so I think just even having that trauma lens for some of our work with children and adolescents can be really helpful in in trying to address a client or a child or adolescent as a whole being with agency and with experiences that we can support and validate and also educate them on too.
Well, and I think that there can be a tendency for adults sometimes in any space to kind of dismiss some of those, breakups and loss of friendship and so on as, oh, this is just some kid stuff. Because I think we forget that, how impactful it was when we were adolescents, and how the loss of a friend or the changing of a nature of a relationship, even into adulthood, we all still struggle with that. It's hard for us to break up. It's hard for us to lose friends. It's hard for us to change jobs. And so seeing how that's paying attention for those kind of things, the things that we might not necessarily, or parents might not necessarily think of as significant, how they can be playing such a big part in whatever is going on at the moment. We have a question that talks about or asks, how do you go about building a rapport with children during the first counseling session?
Yeah, well, I think first and foremost, that piece that I was talking about in confidentiality, and also my relationship and with their parent or guardian as well, that kind of sets the tone for, I think, building trust, and also setting norms for how the counseling relationship is going to go. And then I also think that it's important to remember the importance of play at the children, adolescents, also for adults too. Play therapy is also for adults. And, you know, some of us might not be trained or certified in play therapy, but at the very least, doing activity-based interventions for children and adolescents and being very intentional about what those interventions are. And so often, you know, after I explain the informed consent, the confidentiality process, you know, my philosophy as a counselor, all of those things that help to set expectations and the tone, I will engage them in an activity, even over Zoom in the telehealth setting. Engage them in activity just to get to know them outside of that presenting concern that might be on paper or all that we kind of suspect is happening or heard is happening from other people. Letting them know that like they are the center of this time together, and doing that in a way that kind of enters their world. And so oftentimes for that first session, I'm doing some kind of game, some kind of activity, some kind of play in order to break the ice, get to know them outside of, again, just that behavior that they're there to address.
Thank you for answering that. We have another question that I think ties into this. At what point, and this comes from Amy, thank you for your question, Amy. At what point are counselors legally bound to share aspects of therapy sessions with the parents? And what if the child or adolescent doesn't want their parents to know what's discussed in the sessions?
Well, so anytime that we're heading into the realm of risk, so that could be suicide risk, risk of harming self or others, anytime that we're venturing into the realm of abuse, and that might be, you know, sometimes with children or adolescents, it's the parents that are abusive, and so that might mean that the parents aren't necessarily involved in that communication, but we're that mandated reporter role. And then there's all these other things that could come up that maybe aren't within the realm of legal responsibility, but could be helpful for parents to know or be aware of. And that could be as simple as some of the triggers that their child or adolescent has, or some of maybe there's risky behaviors happening. And those things that might not be within that legal realm of what you're responsible for sharing, but could also be helpful for, again, that systemic change. I think that's where you lean into the relationship that you have developed with the child or adolescent, and like, hey, you know, I'm really concerned about you. You know, based on what you're telling me, I think that it could be really helpful if we let mom and dad know, or let guardian know what's happening. What would you ideally like that conversation to look like? What aspects would you feel comfortable sharing at this point? And maybe that's not now, maybe it's 3, 4, 5 weeks from now, but is this something that you're even willing to continue to check in on and see, you know, gauge that kind of readiness for having that conversation? Is that a conversation you want to have totally on your own, or would you like me there? And so again, that piece around agency and creativity around you know, what that could look like as far as what could be helpful to that systemic change, but then also ultimately what's helpful for that client, and helping them to develop that agency over their counseling experience, but then also just over their lives as a whole.
Thank you for that, and a great question, Amy. I have a follow-up question for that. Are there any differences in confidentiality or sharing requirements when you're working with kids who are, you know, in the system? They're in foster care, or they have been in group homes, or, you know, just all of those various places, detention centers, all of that. Are there any differences in what can or what has to be shared because of the kind of legal implications of their status?
Yeah, so typically the legal aspect from state to state is pretty consistent, but there could be like protocol changes for if you're thinking about the school context versus a residential. So when I think about my time in residential, there were some things that if those like if there was destruction to property or significant harm to like another resident, then it was part of that protocol for like insurance and liability purposes that we would have to get police involved. Versus in the school system, during suicide risk assessment, it was policy that after we kind of assess risk and we go through that conversation, that we do notify parents before that child returns back home. And so that timing piece was really important in the school system. And then in the residential piece, there's certain things that if this was happening, we had to involve a crisis team, or we had to involve, in some cases, emergency services. And so those protocols, I think, can look different from setting to setting, but those overall, like, we're always going to do something if there's abuse of a child. We're always going to be in that mandated reporter role, and those steps might look different from state to state, but ultimately that mandated reporter role is something that's pretty consistent.
Thank you for answering that. Again, folks, just a reminder, if you've got any questions that you'd like Dr. Cabell to ask or answer, feel free to hit that Q&A button or hit the chat button. We'd love to know what's on your mind. I think one of the questions that I saw from some folks who signed up was, if you're interested in starting to work with children and adolescents, what are the first steps that you should take?
Yeah, well, it's always interesting to me too. I started off talking about the importance of knowing child and adolescent development, also neurodevelopment too, right? That children and adolescents, that prefrontal cortex is still developing. And now we know that it's still developing, up until the age of 25. And we've changed, to going back to emerging adulthood. But in some ways, you can think of like 21-year-olds as adolescents too. But just even that child development and neurodevelopment piece, and I think is something that is usually, in some cases, not a requirement for our programs. Often it's an elective course. And so if you're still a student, I definitely recommend leaning into those classes if you have the opportunity to take them. I also think, when I think about my own training, play therapy I didn't really have the opportunity to have like a whole course on play therapy. And so I think if you're interested in children and adolescents, one, if it's in your master's program, that child and adolescent development course, or if there's course on neurodevelopment too. And then if that's not possible in your master's program, thinking about post graduation professional development, that you can get those experiences in those areas. And that could be from conferences, webinars, books that you read. It could also be in supervisors that you choose. And so really being mentored by supervisors who specialize in this work can be helpful in getting your foot in the door around just the knowledge base. And then I also think if you have the opportunity to at least read articles on play therapy interventions or activity-based interventions, again, same with conferences or just extra readings that you can do. I think, one thing, if I was looking back, I would have really appreciated having more opportunities and experiences around play therapy and how I can be intentional about play. Because it's not about just doing an activity for the sake of doing an activity to break the ice so that you feel more comfortable, but it's also about how is, even through this activity, I'm learning more about this child or adolescent. I'm entering their world in a different way than when they first started the session with me. How am I using even this basketball game to ask questions that are helpful in understanding the the clinical aspects of the things that we're working on together. And so I think those two pieces around development and around play, activity-based interventions could be really helpful, just professional development opportunities to look out for.
Fantastic. We have another question. I think this is a good one too. How do you approach talking about racial identity as well as racial inequity in a group therapy session with children?
Yeah. Um, excuse me. So it could also start before the group therapy session even starts, in what your topic is for group therapy, and explaining that, and how, these are the things that we'll talk about, and one of those things includes race, culture, gender expression, things like that. So it could start just even in that screening process, initially telling parents about or guardians about the groups, and then explaining that those groups to the child or adolescent. And then it can also be through that modeling piece of, if I share a little bit about my background and how that's going to play a role in our time together, then we can also facilitate an opportunity for the children, I guess, in a group setting, children or adolescents to share that as well. And I think another layer of that is through that intentional play or activity base, having an activity, just even that first group session that's geared towards sharing more about yourself and your identity. That could be through drawing, that could be through, that activity that I do often, where they have kind of like a blank outline of a person, and they write kind of on the front what people see and about them when they first meet them, and then on the backside of that same person, what people don't see about them. So just even intentional activities like that get them drawing, get them interactive. They can color it however they want to color it, but then also are very intentional about bringing in discussion around social identities. Can be really impactful and important to the work of the group that you're running. And I would say that that's also similar feedback, and I would have a similar answer for working one-on-one with children as well.
Thank you for your answer. I think that's a good question. I think that it's a timely one too, and especially resonates the speaking with the parent ahead of time if you can, but I think maybe also understanding for some children and adolescents, their parents will not be open to that conversation. And that's something to navigate as well.
Yeah.
Folks, we have about 20 minutes left, so I just want to make sure if you have questions that we're getting those in there. I'm also going to drop Dr. Cabell's Instagram and Twitter handle and website in the chat, so you all have that, so you can check out more about her work and what she does. And again, thank you so much for being here. I think this has been a really helpful and open conversation. One question that I have to kind of continue on is, when you are dealing with challenging topics, with children, whether they do or do not have parent and guardian support in tackling those, when there are areas where you feel like the question is out of the scope of something that you can necessarily understand or assist with, or you think, maybe somebody else is the right person to help, because that'll happen sometimes, right? What is your process for determining, okay, it's time for me to refer either, just the specific piece or in general to somebody else? How do you approach that with the child or adolescent? Just with that, that it's a vulnerable relationship, and that relationship transition can be such a big thing too.
Yeah. Just even as you were asking that question, I can think of, a recent example of recognizing that, again, psychiatry services have been so rare in my experience with children and adolescents, where I felt like, a referral was needed to a psychiatrist, but I was kind of getting that inclination that maybe, that psychiatrist referral was something that was going to be needed. And so also, again, I think it comes back to that transition piece. And so one of the things that I did is I just put it out there like, hey, as we've been talking, we've kind of done this, and that in order to better support you. And it's not that, and in this case, like it wasn't that the adolescent wasn't engaging or doing like the interventions or the things like that, right? So also making sure that you're articulating that it's no fault of your own, because often children and adolescents, their worldview is very skewed, and they think kind of that something must be wrong with me. I did something wrong if, maybe a referral is needed. And so recognizing like, hey, this is all of the work that we've done together. These are the things that you've been capable of doing and that have worked for you. And still we're kind of struggling with this. And so one thing that might be really helpful for you is thinking about this psychiatry referral. And first of all, it's explaining what a psychiatrist is. Again, that language piece is really important. And also thinking about that the child or adolescent is your client first. And so we're always talking about how this could be helpful for you. And recognizing like, hey, this isn't something that we have to do right now, but I just want to put it out there. And now we're starting a transition, right? We're at least introducing the idea. You have some time to think about it, give me some feedback on it. You check in next week about it. We see if there's any questions between now and between the last session, answer any questions that you might have. And it might be a 3 or 4 week transition to that referral to a psychiatrist. And that was just kind of one example that I can think of. But those kind of key constructs that I was talking about with just establishing trust, being aware of the language that you're using, that it's developmentally appropriate, and that transition process is important. And that might look different from child to child or adolescent to adolescent. And so for this, case in particular, it was helpful to kind of have that, 3 weeks we lean into this idea. And it was helpful in also getting that buy-in and having that person say, hey, you know what, that thing that you brought up last week and the week before, I actually would like to look into that. And I've thought about it. And now we have that agency piece, that it's your choice, even in that referral process.
That's a great method. I just that kind of, it's not a surprise, and it's not a fault situation. This isn't like you didn't do anything wrong. This is about best supporting you and, helping them kind of arrive at the wanting that additional support. We have about 10-15 minutes left. So just a quick reminder to folks to get your questions in. Is there anything, that you would tell folks who are, again, we talked about being nervous about working with children and adolescents, but what would you tell folks who are nervous about it, but are still thinking, I think this is the direction that I want to head in?
Yeah, I think, when you understand like neuroplasticity and neural development more, you understand that there is such a large opportunity for children to grow and for children to be resilient. And the earlier that that process starts for them, the better off those long-term outcomes are. And so I think while it's important to be aware of some of the things that I talked about, assessment, the impact of childhood trauma, of thinking about or examining behavior as a form of communication, also recognizing that children are, they have agency, they're creative, they have all of this potential and prospects about them, and they're not, these kind of fragile little things that you have to always kind of second guess yourself about, but that there is a real true opportunity to lean into the relationship that you have with a child or adolescent, and that be the one interaction that changes a whole life trajectory for them. And so there's this really amazing and beautiful opportunity as a counselor clinician to be a part of that some cases, post-traumatic growth process, that resiliency process, or even building those protective factors for children or adolescents. Like you yourself as a counselor clinician could be a protective factor for someone. And that I think is really powerful. And I think also, to me, it's like, why wouldn't you want to do that and have that kind of opportunity to be a part of changing someone's life?
Awesome. Thank you so much. It looks like we have answered all of the questions that folks have. So as we start to wrap up, my final question for you, is there anything that we didn't talk about either by answering questions or just in general that you would really want to convey to this audience about being an inclusive counselor to children and adolescents?
Yeah. I always encourage people, when we think about childhood trauma and understanding neurodevelopment and things like that, to look into the research around adverse childhood experiences, but then also positive childhood experiences. And so it's not that just that, you know, experiencing childhood trauma can be debilitative and lead to all these negative outcomes in adulthood, but that there can be real true opportunities to foster growth and resiliency. And so those positive childhood experiences of having social connectedness amongst peers, of having at least one adult outside the home that children or adolescents can connect with. All of those things have been shown in the research to be really impactful for long-term outcomes. And so just even in your own kind of research or exploration around working with children and adolescents, looking into both adverse childhood experiences and positive childhood experiences as well.
Thank you so much. It has been a pleasure to speak with you today and learn a little bit more about working with children and adolescents. For all of our folks who are attending, you can find Dr. Cabell's Instagram, Twitter, and website information in the chat. I think that this has been incredibly, incredibly helpful. And if anyone thinks of questions after the fact, you can feel free to email me at ani@allcounselors.com. I'd be happy to pass them on and get you some answers. And make sure that you sign up for the oncoming sessions for our inclusive therapy series. Tomorrow we are talking about Indigenous and Native American support, and then we're also talking about working with the Jewish community on Friday. So I hope to see everybody at as many as you can attend, and we will have a replay of this up in the next couple of days. So you're welcome to watch again or share as widely as you want. Dr. Cabell, thank you so much again. This has been a fantastic conversation. I really appreciate your time.
Yes, thank you. And I just want to also just reiterate, feel free to reach out to me as well.
Thank you so much, everyone.